So basically, when you look at the childhood blindness, you have prevalence is somewhere around 6.5%. And it's vary widely from region to region, reasons being socioeconomic development, availability of primary health care, and availability of eye care services. And probably ROP is the second common causes what we have, and that's why we all are here. So can you move forward? Yeah. So under National Health Mission and under with this universal high screening, basically below 18 years of age with early detection and treatment for what they call as almost 30 selected health condition, 4 Ds they are given. I will not going to go detail about that basically. So, and for us, when you talk about universal eye screening, basically primary target age group is early neonates. And probably first screening should be done preferably within 42 to 70 years of delivery. This is overall eye health when they are looking at it. And aim to identify the eye disorders right at the birth or during the stay in NICU so that you can utilize that time to prevent or treat at the earliest for a better final outcome. And also it is important because critical period of brain development is first 2 years. And when you have that cognitive development disorder, what you see during this period, suppose vision is not developed, all these factors get affected as well. Now, what are those newborns at risk for vision impairment? When you look at it, our premature infants comes right on the top. When you have other family history with other ocular disorders, and infants with associated cognitive disorders and neurodevelopment delays also need to be screened for a thorough examination. And when you look at 3 typical examination criteria they are given, let's look at the eye history, significant ocular history, external examination of the eye, and the red reflex. And depending on that, if you have a family history of other congenital disorders, ocular disorders, probably yes, ophthalmologist should be involved in screening of the baby. If you have associated eye problem or some issues with the red reflex, abnormal reflex, and these are the babies need to be screened by ophthalmologists. But other first level, it can be done at the level of neonatologists or NICU nurses. So ROP, we are not going to go much detail. We all of us know here, all our ROP experts are sitting here. And what is universal screening? Basically for ROP, look at it, is to ensure all at-risk preterms undergo systemic eye examination to detect early ROP, which allows time interval to prevent blindness or severe visual loss. And these guidelines probably all of us know. I'll skip this guideline. Clinical protocol, we all know how to screen. And basically, so what you look at is the benefits of universal screening is basically when your early detection lead to timely treatment, helps to prevent blindness, improve long-term visual outcome in preterm infants, and helps track trends in ROP prevalence. That is what is more important for us to better healthcare policy managements. So we have a barriers for this screening. Basically, problem Anand and Dr. Azad always keep on talking about shortage of trained ophthalmologists, limited access to retinal imaging in remote, low resource settings, high cost equipment, and poor follow-up rate once these babies are discharged from the neonatal ICUs. So what are possible solutions we have here is that SNC or NICUs to improve access by working with the local ophthalmic community and hospital administrations. First screening can be done using wide field cameras. Images can be taken by technician and can be reviewed by experts. What you talk about telemedicine, we are coming to that. I think future is that. Implementing AI-based screening program, increase awareness among parents, and that is what is most important issue here. Because if parents are aware, if they ask for screening, probably we will be much better off. And if treatment needed, obviously these babies can be sent to regional centers, or an ophthalmologist can visit these NICUs to treat these babies. So indirect ophthalmoscopy obviously is a gold standard, but using wide field digital camera has its advantages because it is technician based. Images can be stored, transmitted for expert opinion, reviewed, analyzed, and sequential comparison can be done. And also it can be, so now new cameras are coming with a small pupil, so dilatation part, risk of those toxicity also can be minimized. RedCam, yes, is a gold standard. However, it has its own issues. Cost is huge. So we have now a lot of handheld, wide field cameras, and even smartphone-based screening protocols are coming up. And We are having a new technician-based screening models or mobile screening units can be, and cloud-based platform for remote consultation are also being tried. And best example what we have is KID ROP is the model. What is important is keeping up those follow-up records. Though each institute has their own format, it is important to document these findings and management decision at each visit. The data for next screening, if needed, must be documented in the medical record, discharge summary, and must be communicated to the parents verbally and in writing, because that will be issue of medical legal issues. And it's good to have a automated reminder system for the parents. So to implement this this universal eye screening, so universal vision screening should be done at all delivery points through doctors, that is neonatologists will be there, obstetricians will be there, A&M staff and nurses. State and union territories should establish at least one state level apex unit for ROP, which should function as also as a training unit. This unit to be located at SNCUs or NSCUs of government institute with facility for indirect ophthalmoscopy and dedicated laser, and also possibly should have wide field imaging system. Both screening and treatment should be done at SNCU, and at least 2 beds to be reserved to the ROP procedures and dedicated radiator warmers to be earmarked for the same. At least 1 doctor and 1 nurse for NICU be assigned and trained for screening and the treatment, and identify ophthalmologists in government or private sector who could visit NICU or at least once a week and should be paid accordingly. Help from collaborative centers if necessary to be sought, and ROP screening in National Health Insurance Program to cover this treatment cost is equally important. When you look at mapping services, you need to have accountability also. So you need to assess the workload to prioritize the implementation of screening programs. We'll look at the government database, availability of ophthalmologists in regional institutes, medical colleges and district hospital and private sectors, their competence, willingness, and to get trained for screening and treatment. And that is what is important, because compensation has to be there. Availability for necessary equipments, we look at it, and location and equipment really doesn't cost. Indirect ophthalmoscopy, lens and dilatation drops probably should not an issue. Look at district early intervention centers where training staff level for equipment and eye care as per RBSK guidelines should be there. SNCUs with adequate load to be upgraded as a nodal center for teaching and training, and can collaborate with RIOs and other medical colleges as well. When you look at a quality improvement, and that is what comes again, probably what she has last presentation will help us. Training for a personnel to deliver best practices, written protocol for screening, treatment, follow-up and record keeping that gives a uniform way of recording as well as screening, and that will help us future analysis and studies if you plan. ROP screening should be completed prior to discharge, that is the first examination preferably. And if patient has discharged, prior fixing of screening appointment must be made with nearby screening centers. And it should be documented in discharge report, and parents must be counseled for that. And we try to establish probably national registration. And to validate this, of course, you need a certain parameters, so you need to audit this. So competence of screening program, that's last one, yeah, thank you. So completeness of screening program, which includes percentage of eligible babies who received at least 1 eye examination. Look at the timing of the first screening. So percentage of eligible babies receiving first ROP screening examination by 4th week of postnatal age, and percentage of babies needing ROP treatment are treated within 48 hours of making decision. If you audit this, probably again you will help to maintain the quality. These are our responsibilities. I am not going through in details. This is all we know on RBSK guidelines. Also health communication, what I mean is basically awareness, public education, awareness of healthcare workers using posters, booklets. For parents, sometimes have like what Anand just was showing, our posters, banners, audio visual shows, and if you have ambassadors to help this create more awareness. The word about just artificial intelligence, and that is what is going to come up now. We need to have AI-driven algorithm, a promising tool for automated ROP detection, and also will help to analyze retina images. The basic advantages are it will be automatic diagnosis, increase accessibility, improve accuracy and consistency. What protocols we have, somewhere around 90 to 93% sensitivity. It obviously helps up speed up decision making, but also help us to take challenges like limited specialty availables, high patient load, delayed dissection. That is what it is going to take care of. But however, it has its own limitations because variability in image quality, how the way input will be, that is important. You need a regulatory approval for that, for government organization, ethical and legal concerns, and it has still limited generalizability, which probably have to work on it. So I think that's, I'll conclude with it. Thank you very much.
Thank you, sir.